The following paid program does not necessarily reflect the views of this station, its staff, or iHeartMedia.
Live from downtown Honolulu, it's The Moving Body with your host, Dr. Bernie Portner of Portner Orthopedics, recognized as Hawaii's leading sports medicine and orthopedic specialist. And now, here's your host, Dr. Bernie Portner.
Good morning, Hawaii, and welcome back to The Moving Body. Hope you enjoyed the first hour show. I listened to it on the way in a little bit. And now here we are live on Saturday, the 28th of February, which, unless this is a leap year, which it isn't, this is the last day of the month. So tomorrow is March 1st. Happy birthday, March, in Michigan, where I grew up. We had this expression, march in like a lion, out like a lamb. But here in Hawaii, it's march in like a lamb, out like a lamb, I suppose is the best way to put it. Because it's lamb weather around here all the time. 521-8383. If this is live on February 28th, 2015, give me a call. And the lines are open. Arm, leg, neck, or back pain. Outer Island listeners or iHeart Radio listeners on the mainland, 1-888-565-8383 will get you here. So, pretty interesting show on the way in. I don't know how many of you were listening to the first hour show, but it brings up a lot of very basic and important points, one of which struck me as the whole basis of orthopedic medicine. And it's one that's lost on many, not just people and not just physical therapists and not just, but doctors themselves are, in fact, more so doctors and therapists, I would say. The principle is this, is that regarding injury and referred pain. The body part that hurts may be different than the body part that is injured. And there's a lot of explanations and theories as to why this is the case. But the interesting thing that came up in the first hour show was this, that when a body part is injured, the injury results in some kind of abnormal functioning of that body part. By functioning, I mean motion and free of pain. So if the shoulder is injured in some way, whether it's an arthritis or a tendonitis or a ligamentous sprain or a bursitis or a rotator cuff tear or whatever is bothering the shoulder, it will invariably, and I use the word invariably, and it makes me pause because there's always an exception, practically invariably will result in a loss of motion of the shoulder joint. So you won't be able to reach up as high to the ceiling with the affected shoulder, painful shoulder as the other side, or reach behind you as if, I don't know, scratching the middle of your back or putting on your bra strap, or reaching around in the back of you to get something in the back seat of the car. Some motion will be limited and or painful. If somebody has shoulder pain, they come to me, Dr. Portner, can you help me? I had this nasty shoulder pain for a long time already, and can you help me? And I said, let's have a look at it, and I move the shoulder up, and I move the shoulder back, and I move the shoulder forward, and I twist it this way, and I twist it that, and all the motions are full and without pain. I have to conclude that although the pain is being perceived in the shoulder's completely normal. If it wasn't, then one motion or another would be affected. It seems so obvious, and it seems like I'm beating a dead horse here, but it's surprising. It's disappointingly surprising how many times doctors miss this, and someone has a shoulder pain and they order shoulder massage and they order shoulder x-rays and shoulder MRIs and shoulder injections, and so even, believe it or not, shoulder surgery, and they've failed to demonstrate that the shoulder is the source of the pain, because if they had tried to move the shoulder every which way, they would have seen that it works normally in every direction. That came on in the previous show. I guess it might be boring, but it's so basic to what I do, and it's so lacking in many practitioners' repertoire that they end up treating and emphasizing the wrong area, because they're misled into thinking that wherever the pain is, that must be where the problem is. Referred pain. And we can talk about about that more as the show goes on. I'm waiting for my first caller, 521-8383. Very interesting week at the office this past week, and I like to, especially when I don't have callers, I like to share some of the more interesting examples of patients that I saw. One of which comes to mind is this middle-aged woman in good health, a little bit overweight, comes to me with back and buttock pain, a little bit down the leg. Been diagnosed as having a disc problem. Her x-ray shows degenerative disc disease. And as an aside, almost anybody's x-ray you take over the age of 40 or 50 will come back with the diagnosis of degenerative disc disease. Discs wear out. It doesn't mean they cause pain. They wear out. They become less thick. They become a little drier, less water. They sometimes crack. And it's, in some regards, a lot like the aging that causes your hair to turn gray and the aging that causes your skin to wrinkle. It's not necessarily a pathology that causes pain, and yet when you have back pain and you go for an x-ray and it comes back degenerative disc disease, your doctor, puts 1 + 1 together, comes up with 2, and says, yeah, well, you got back pain. Look, you got degenerative disc disease. This lady I'm trying to talk about, after I examined her, it was her sacroiliac joint just below and to the side of the spine that seemed to hurt when I moved it, when I pushed on it, when I challenged it, when I provoked it. And I said, you might have degenerative disc disease in your lower back, your lumbar spine, but your exam tells me that it's coming from your SI joint. No wonder, if I'm right, no wonder all these treatments you've had all these months haven't done anything. It's been directed at your back. Let's try something to see if I can help your problem and also nail the diagnosis. And carefully under x-ray control, I place a very thin needle after I numb everything up so you don't feel it. I place a needle right into the sacroiliac joint. How do I know it's in there? Before I do anything else, once I'm convinced it's in the right place, I inject a little dye, some contrast material, take a quick fluoroscopic x-ray right in the office, and I see the dye filling up the joint, and I know that the needle's inside the joint. Then I put in some Novocaine-like medicine and a little bit of cortisone-like medicine, and I wait a few minutes, and then I re-examine the patient, and she has no pain, and all the tests that I used to test the SI joint before the shot are now normal. They don't hurt, and they go, and I see her back. I just saw her back this past week, and she's pain-free for the first time, and I don't remember how many months, but many, and very happy. And I have chicken skin just telling you this story because that's what keeps me going. That's what keeps me from retiring, is when I can help people get rid of painful conditions that affect their life. The point of the story is that a careful diagnosis and a carefully aimed needle right into that diagnosed area, that in this case joint, can change a person's life. She's now back to work. She now can do all those things, go to a movie, she can sit, she can walk, and it's because I was able to diagnose her and treat her, and that's a very great profession that I have. Anyway, we'll talk about that. But Jim, you've been waiting patiently. Go ahead, you're on the air, and thanks for calling.
Hi, doctor. I'm 76 years old. I used to be a very strong swimmer, and I used to pitch, and I used to throw the javelin, and my right shoulder over the last, say 4 years, I was unable to use it to stroke in a freestyle in swimming. I couldn't lift it up over my shoulder. And recently I had an operation. They put in a new thing in the whole leg shoulder. They put a piece of metal down my bone and a metal cap on there. And now it's been 2 months or so, and I'm suffering through the recovery exercises. They're very painful, but I got to do them every day. I wonder how often this happens, and I'm hoping for good results that I can swim again properly.
Yeah, Jim, let me go over your history just so everybody understands. I think I understand. You injured your shoulder somehow about 4 years ago after living a life which was rich in physical activity, especially using your shoulder. If you're a pitcher and a javelin thrower and a swimmer, that's all high-intensity shoulder activities. Finally, you go and get your shoulder joint replaced. Is that what happened?
Yes, they replaced the shoulder, yeah.
The ball and the socket.
Yeah.
Because it must have been on X-ray, an MRI, I suppose, that your shoulder joint was worn out. It was bone on bone.
Yes.
And there was spurring, and there was loss of joint space, and there was sclerosis and calcium, the whole shebang. They cut out the ball, they cut out the socket, they put in a new ball and socket shoulder joint, and you no longer have arthritis, but you still have pain.
Well, I have to do these exercises.
Yes.
They're supposed to do 5 times a day.
Yes.
And they're very painful to do darn things. And I have not really done them 5 times a day.
Let me ask you this. Excuse me for interrupting, Jim. How is your shoulder now when you're not doing these exercises? How is your shoulder pain now and your shoulder motion now compared to how it was before the operation?
Well, I mean, I don't have pain walking around. But
did you used to before the operation?
I don't remember that either. But it's just when I try to swim and lift my shoulder up, and do things like that, it became limited. Now it's becoming, I'm doing more and more, but it's slow progress, and it's very painful now to move it in certain ways. I have to do.
Are you able to swim now?
Yes, I was swimming, but not as well as I should. I still can't lift it up.
The question I'm trying to get answered is, can you swim now better than you could before the operation?
Let's see. I probably can, yes.
And what other activities have you started to do again since your operation that you were having trouble with before besides swimming?
Well, I haven't really done anything. So I haven't been to the gym for quite a while. I used to lift weights too, but I haven't been there. I have light weights that I lift here.
And when you lift weights, is it easier now to lift weights than it was before the operation?
Not really, no.
Yeah. So what I'm trying to get at is, you asked me a question, and if I'm not mistaken, the question was, is what you're experiencing with this very slow and somewhat disappointing improvement and recovery following total shoulder joint replacement, if that's common. Is that what you're asking?
I guess this is normal. What can I? Yeah.
And I don't know the answer to that. I'm not a surgeon, so my experience with post-surgical total joint replacement of the shoulder is not, is somewhat limited. I've worked with people, but how common it is not really that important. It's, in your case, it is common because you're having it.
Yeah.
The question is, it's only been 2 months. What does your surgeon have to say when you go to him and you say, Doc, you know, I really appreciate you replacing my worn out shoulder, but I'm still having a great deal of difficulty. What do you have to say about that? What does he say about that?
Actually, they say it takes a year or so to really to get.
So he's not concerned to the extent that, wow, this is very unusual.
No, he's not. No,
his impression is that this is what it is, and it's going to take a year before this fully gets functional again.
Yeah.
And did he tell you that before the operation, that it's going to take a year?
I can't remember, but he spelled it out pretty well, and
Yeah.
I looked it up in some places. It says 2 years.
Yeah. So I guess it's only 2 months.
Yeah.
And how old are you?
77.
Yeah. And you're in good health otherwise, I take it?
Pretty good, yeah.
No diabetes?
No.
You eat well, good nutrition. Are you overweight?
Slightly over, but I'm...
All right. Slightly's fine. And do you have some activities that you can do without difficulty? Can you swim the breaststroke?
Oh, yeah.
That doesn't hurt.
No.
And but you can't do the crawl because you can't fully reach out with your new shoulder joint. Is that right?
Exactly.
Yeah. So go ahead and do the breaststroke, and because at least you can get your exercise and be in the water and stay healthy, and do your rehabilitation like they say. Are you doing exercises under supervision with a physical therapist or completely on your own?
Well, I do them on my own at home, but then once a week I go into a physical therapist now.
Right. And your concern is that this has taken so dang long.
Yeah, I'm just wondering what normally, I guess I'm actually doing fairly well, I guess.
Maybe. I don't know. It seems to me that you have to keep up the good work and hope and watch and see that every day and every week that goes by, you make little baby step improvements. And by the time it's Christmas, you'll be good to go and do the crawl.
Here's hoping. I was just looking for a magic pill, the new pill called 16.
Yeah, that would be a good one, I suppose. But then you'd have to have acne and be awkward.
Oh, dear.
and not call girls to go on a date because you're too nervous.
Oh, boy.
So there's advantages to being 76 because people our age don't give a crap about all that. Life is a little bit more relaxed. Just keep it up. Do the exercises you can. Don't be inactive. Watch your weight. It sounds to me like you're a little overweight. You didn't used to be.
Oh.
And, pay attention to your general health. Do what they say. Don't exercise if it's really painful. You don't want to kill yourself with pain. But follow the orders of your physical therapist. They're very, very skilled and good and experienced at taking care of this kind of stuff.
I'm impressed by them.
Yeah, I think you got room for optimism here. You just need some patience.
Thank you, doctor.
All right. Take care and good luck with this, Jim.
Thanks a lot.
Yeah. Bye-bye. Let's see. You're listening to Dr. Bernie Portner. The number here, 521-8383. Give me a call if you're having any problems with your arms, legs, neck, or back. I have another patient, similar age of my last caller, Jim. Similar story in a way. He had about 4 or 5 months of shoulder pain, and he was getting treatment, non-surgical treatment, and he was making progress, but golfing and surfing, he couldn't really do either very well because of his shoulder injury. And he became impatient. He went and saw a surgeon, and the surgeon looked at him and looked at the MRI and said, "Oh yeah, I can fix this. Let's do surgery." And out of desperation and against my better judgment, he went ahead and had the surgery. And he's a miserable camper right now. Now, it's true, it's only a few weeks since the surgery. but he's in far more pain. He regrets having the surgery. I'm trying to be positive and reassuring that you can't judge an operation like that. Now, that wasn't the same kind of operation. It was not a total joint replacement. It was a rotator cuff repair. But you can't judge that operation. You can't judge either of those operations in just the 2 or 3 weeks. You have to wait. You have to give it time. But he's far more miserable and than he was before the operation, and is very fearful that he's not going to recover. Chances are he will, and chances are he'll get better, and chances are he'll get so good that he'll be more or less cured and be able to golf and surf again. But it may take many months, many, many months. And if he hadn't had the surgery, no one knows, and no one will ever know. But in my experience, he might have been just as good in a few more months without the surgery and without all the post-operative pain and frustration and buyer's remorse, if I can use that term, buyer's remorse. He regrets going through it. He would never do it again, he said, because he's having the worst pain in his life. And I said, the only reason you're having the worst pain in your life is you've never given birth, because that's worse. But operation, it's not for the faint of heart. You know, it's big time recovery. It's like getting injured when you have surgery. It's like getting a big time injury, and there's a recovery period. And I'm not a surgeon, and I specialize in approaching these orthopedic problems in a non-surgical way. But let me also say this. There are conditions, orthopedic and otherwise, where surgery is mandatory, where surgery is the treatment of choice, where surgery is sometimes even the most conservative treatment. And what I mean by conservative, it means the most safe, the least, the treatment that offers the least amount of risk. It sounds counterintuitive because you think that surgery is very risky, but there are times when surgery is imperative, and if you don't do it, you risk great peril. You know, if you have a herniated disc and it's pushing out a nerve, and it's the nerve that controls your bladder, and you're losing control of your bladder, if you don't have an operation real quick, you may permanently be incontinent, have urine accidents all the time. So in that case, surgery is the most conservative and imperative thing to do. But that's another story. 521-8383. Give me a call if you have any questions regarding arm, leg, neck, or back pain. If you just tuned in, I am Dr. Bernie Portner, your host today and every Saturday at this time on a show that we call The Moving Body. We talk about the body parts that move, the parts of the body that give us motion, and the parts of the body that, when injured, causes us to have difficulty moving, to do our sports, to do our exercise, to do our job, sometimes just to sit in a chair. You know, the biggest cause of lower back pain, which is probably the most common condition not only that I see, but one of the more common conditions that your general doctor sees, perhaps second only to like a common cold or flu-like syndrome. A lot of people go to the doctor when they have fever and stuffy nose and sore throat and cough. But aside from that, low back pain is way up there in terms of most common things that bring the patient to a doctor, just a regular doctor. And in my practice, where all I see practically are arm and leg and neck and back pain and a little jaw pain and a few other conditions, back pain is on the top of the list. And the most common cause of low back pain is a disc problem. And one of the biggest complaints of people with back pain caused by a disc problem is, I can't sit. I won't go to a movie because I just get so uncomfortable. I have to stand up in class because I'm a student, and if I sit down in class, I can't make it through the hour. My back becomes so sore. I end up standing in the back of the classroom. So it's not just movement, but sometimes position or posture or just sitting still. And those of you that have heard this show many times before have heard me talk about spinal stenosis, the second or third most common cause of low back pain, usually seen in people in the second half of their life. And people with spinal stenosis, they can sit fine, they can't stand worth a lick. So they have trouble like at the grocery store. They have to stand in line to check out. They end up holding their shopping cart and leaning forward on it. And next time you go to the grocery store, you'll see a few people, usually on the older side, 50 and up, and they're walking up and down the aisle, and walking fine, and they're holding onto the cart with two hands, just about like everybody else, but they're leaned forward. They're a little bit away. They're a little bit moved away behind the cart, and they lean a little forward. And these people, you can see them. Next time you go shopping, you'll see some people in their 50s, 60s, 70s, and up, and they're leaning forward on their shopping cart as they walk up and down the aisles. These people have spinal stenosis. It's an incredible phenomenon. The shopping cart sign, we can call it. I think there are people that talk about it that way. Anyway, the lines are open, 521-8383. A couple of clinic announcements. Let's see. What's news at the clinic? Well, I guess everybody should know by now that the clinic moved from Pi'ikoi Street to Bishop Street. We moved downtown. It was definitely a move up. And very happy there. What's difficult about it is my address and the map that leads you to my office is on the internet and many different websites. And many of those aren't changed. It's difficult. So people sometimes look us up, and it takes them to Pi'ikoi Street, and it's a cause of confusion, and sometimes, rarely by now, because it's been several months, but rarely people will make an appointment and show up on Pi'ikoi Street. It's a big embarrassment, and it's a hassle, and it's extra grief, and they're already in pain, and I apologize for that. But it's a process to get all those maps and MapQuest and Google Map and Facebook and websites and doctor search engines, and there's so many, and some of them just haven't yet been discovered and corrected. We're working on it, though. If any of you have experienced that, I apologize. Our office is on Pi'ikoi Street. Of course, we still have our office over in Kaneohe on Kamehameha Highway over by the shopping center there in the American Savings Building. And Dr. Fernandez is there almost every day. I know he's there Tuesday, Wednesday, Thursday, and half-day Saturday. He's there today. So if there's any people over on the windward side and they have an arm, leg, neck, or back pain, they can see Dr. Fernandez, and even on Saturday. You can call the office. I'm not sure if there's yet someone there to answer, but leave a message. They'll call you back. The number for both offices is 596-7300, 596-7300. And, you know, a lot of you are listening, and I know you have a back problem or a stiff neck or a shoulder pain or a numbness in your hand or a hip arthritis or a knee problem, and so on, and are too shy to call perhaps, or can't call. You might be at work or you might be driving. But take care of it, and you can easily do that. One option is, of course, to call my office and come see me or Dr. Fernandez or Dr. Bro. Another is just to see your own doctor. You know, it's simple. It takes a little effort, but it is your body. And here I am. I'm right after the show, I have to go get a blood test because I have an appointment with my internist, Dr. John Mickey, very great doctor as far as I'm concerned. He's been my doctor since forever. And I have my annual physical at least every 3 or 4 years, whether I need it or not. And it's coming up. I'm going to talk. I have a situation. It's my own personal situation, but I'll share it with you. Why not? Everybody else calls here and shares their problem. I'm told I have sleep apnea. Now, it's hard to know if you have sleep apnea yourself because you're asleep. And the thing about sleep apnea is your airway is blocked. Your throat collapses, and your airway is blocked, and you can't breathe, and your oxygen in your blood goes down, and the carbon dioxide goes up, and then suddenly something, probably one of those two things, wakes you up, and you suddenly snore and make a lot of us have heard this, suddenly after breathing not at all for some seconds, and that's sleep apnea, and then you wake up. And in the past, I'd wake up and I'd get up in the middle of the night. I thought I got up because I had to pee, so I'd go pee. Because what the heck, it shouldn't be a total loss. I go back to sleep, and then sometime later, same thing. Of course, I wouldn't hear myself snore, but I'd get up and I said, "Oh, geez, I got to go pee again." So I'd go up. And a lot of people think that they are getting up because they have to go to the bathroom often, when in fact they're getting up because they have sleep apnea. And sleep apnea is a dangerous condition. It's associated with heart attacks, strokes, and a whole lot of other things. One of the causes is obesity. So I was technically obese by the numbers. I'm 6'1". I weighed about 230, and my BMI was 30. And BMI is body mass index. It's a way to measure your overweightness, and it should be below 27. So I said, okay, I'll try hard, I'll lose weight, and that's supposed to help sleep apnea. Sure enough, I lost the weight. My BMI is now down to 27. I lost over 20 pounds. I can talk to you about that also. But my sleep apnea persists, so I'm going to my doctor, and I'll get a referral for a sleep test. And I'll let you guys know how that does. They'll diagnose sleep apnea, and if I have it, which I'm pretty sure I do, I'll get this breathing machine that I'll have to get used to, and my wife will have to get used to it. But she's gotten used to the snoring. This will be easy. And this sleep machine will, if it works, will stop the snoring and stop the sleep apnea and stop me getting up in the middle of the night 10 times. And I'll spend the day much more rested. I won't feel tired. I sometimes feel very tired during the middle of the day. So this is not my field. I'm talking about sleep apnea, but it's a very important condition. It affects people, especially men who are overweight, and it causes serious problems, including death. So I know this is an orthopedic show, but I'm just sharing here. And it's something to be aware of. Ask your doctor about it. Ask your spouse about it, because they'll know if you're a loud snorer. And then if suddenly they notice that there's no breathing at all, no snoring, no heavy breathing, it sounds like you're not breathing. And then after a few seconds, sometimes 5 or 10, there's a sudden loud breathe again, and you wake up and stir, and then you go back to sleep. That's sleep apnea, and it can be diagnosed and treated. But what am I talking about it for? I got it. I don't know much more about it. 521-8383. If you have any questions regarding arm, leg, neck, or back pain, don't hesitate to give me a call. The lines are open, which is unusual. We have another 15, 20 minutes to spend together. And I'd like very much to try to help you out and give some advice if you have any questions for me. If you're listening from a neighbor island and it's February 28th, 2015, call me at 1-888-565-8383. Some of you may have heard that I'm getting into the area, the field of weight loss. And this is not completely out of my realm. I started out, of course, as an internist where I took, this was back in the 70s, I took a very special keen interest in weight loss and developed this very low-calorie, high-protein diet, which is not much different than what a lot of these commercial diets are all about. They give you very low calories, but make sure you don't lose protein. And we're starting that now, but I went into rehab and then into a subspecialty of orthopedic, non-surgical orthopedic medicine. But to rehabilitate my patients with bad arthritis of the hips and the knees and bad conditions affecting their low back pain, I've decided to, instead of just telling them, hey, go eat less, go lose weight, I've partnered up with this program on the mainland called Robard, and I'm starting Monday having my first patients in the program. So we are helping people lose weight. You can call the office 596-7300 and come talk to me about the program if you like. It does work. It is safe. And the trick is, of course, not getting it off so much, but keeping it off. But this is what we have to do. We're a nation that's way too fat, and the cards are stacked against us. And the industry, the food industry, the fast food industry, the prepared food industry, the pharmaceutical company, they're stacked against us. We're supposed to be overweight. It makes them rich. I'll tell you more about that. Let's see. Daniel's been on. Daniel, sorry to keep you waiting. You're on the air. Thanks for calling.
Sure. Thank you. I'm 57. I've been healthy my whole life, all my joints and everything. And just about 10 days ago, I apparently overstrained my left knee. It's on the inside of the left knee. And I was wondering what kind of foods, other than keeping the weight off it, cold compresses, things like that, what kind of foods that might nurture the healing or speed the healing of this knee.
Okay. And do you remember injuring it? Was there a fall or a twist or overdoing it? How did this come on?
Actually, nothing in particular, but I did notice about Monday of last week that over the course of about 3 days, it just started swelling up, and I was carrying a bit of weight to those 3 days, but it didn't seem to be any one movement that caused it.
And so let me go to your question. I just needed some background information. Let me go to your question. When you first asked me, is there some sort of food that can help me? My first thought was, oh boy, not at all. This got nothing to do with food, and you're asking the wrong question. You want to ask, what is this? And then ask, what can be done about it? Not to work backwards and think of a possible solution and ask if that's the solution to your problem. But after I started to hear that you didn't get injured, I'm going to not say that right off the bat. What I'm going to say is there is that I can think of one condition that can cause the knee to spontaneously begin to hurt. That means without apparent cause. That is affected by diet, and that is gout. I don't think this is gout. Is the knee swollen, red, and warm, and very difficult to move, and very difficult to touch?
Well, it was swollen. At about Wednesday of last week, it was swollen up.
Do you have a history of gout, or does anyone in your family have gout?
I've been in great health my whole life.
So gout is the one thing that can cause the knee to become painful and swollen that is very much affected by what you eat. Foods high in purines. That's
right.
That's sweet meats, shellfish, rich foods. It was once called the rich man's or the king's disease, because only people that could afford to eat rich things would eat foods high enough in purine that it would make crystals in the knee. But otherwise, it's a fallacy in my humble opinion, and I say that because I could be wrong. But it's my opinion that most of us eat plenty of essential nutrients that we don't have to change our diet necessarily in order to avoid painful knees. The chances are you overdid it with carrying of this weight, maybe tweaked your knee and didn't even notice, and then developed this pain on the inside aspect of your knee. And this is persisting. Is that still the case?
It's gotten a little better because I kept the weight off it.
If you touch
is there any idea? Go ahead.
If you touch your knee, I didn't mean to interrupt you. If you touch your knee right at the spot where it hurts, is it very tender there? Can you find a spot that you touch and you go, wooey, that hurts?
Yeah, it was a lot more sensitive.
Yeah.
It's gotten better fairly in the last 5 days. It's improved considerably. I was just wondering, like, roughly how much time you think if it's healing to this rate. And I've been very aware of the weight thing.
I'm going to try my most fun hobby to do on the radio is to do a physical exam or make a diagnosis over the phone, which listeners, do not try this on your own. Do you surf by any chance?
No, but I'm in the water quite a bit.
Well, you know what I mean by if you put which leg is this? Your right or left?
I'm left, inside.
Your left. Are you sitting down right now or standing up?
Yeah, I'm sitting down.
I see. Stand up. Can you stand up?
Okay.
Stand up for me. Move your left foot out to the side. And then kind of bend your knee inwards towards the other leg. So you're putting stress. You're kind of bending your knee sideways.
That's when the pain. It's not really. I can actually walk up a steep flight of stairs, and there's no pain as far as full extension. But it's when the angle goes toward the other knee inward.
So at the risk of being very wrong, because there's probably something, if not illegal, immoral about making diagnoses over the phone. You may have tweaked a ligament called the medial collateral ligament. That's a ligament that is commonly overstretched. Carrying weights would be easy to injure it, not hardly notice it at first, and then as the swelling and the inflammation kick in, that night it becomes more obvious. And maybe you did that and it's starting to go away on its own, and that's the natural history. It's often self-limited. You say this is about a week old?
About 10 days. In the last few days, it's gotten maybe 40% better, I'd say.
And have you continued to work?
No, I've kept it to a minimum. I'm trying to keep it elevated, and I'm in the water though.
What kind of work do you do?
I do body work. I do massage therapy.
I see. Oh, you're a massage therapist. You know the term transverse fiber friction massage?
Yeah, I heard of that term.
Sports massage. You know, the ligament is going from top to bottom, from above your knee to below your knee. It starts at I can use technical terms with you because you're in the field. It starts from the end of your medial femoral condyle. That's the end of your thigh bone for all the other listeners. And it goes across the joint, the medial aspect of your joint, and that ligament attaches to the top portion of your medial tibia. And those fibers go from head to toe. You know, they're in the direction of up and down. If you put your thumb or finger, or have a friend do this, on the painful site, on the ligament, this is all with the caveat that this is the right diagnosis. If you put your finger on the affected ligament and rub it perpendicular to the up and down, so forward and back, for about 10 minutes every other day, and ice it up before and afterwards, I think you could treat it yourself. Now, you're on Maui, I see, so I can't tell you to come in and see me. You could see a colleague, a physical therapist, or probably a physical therapist, and just say, does this look like a medial collateral ligament? They'll know how to do what's called valgus stress. That's bending your knee sideways to the outside, and that reproduces the pain. So that's probably what you have. But, you know, you have to take that with a grain of salt because I'm just this guy across the ocean talking to you on the
Sure.
phone. I got no
And,
idea. You know, I'd have to examine you myself, but I bet you that's what it is.
okay.
There's, you know, there's other structures, of course, that are in that area. The medial meniscus could be injured and cause pain there. That's one other option. The coronary ligament, which are the outer fibers of the meniscus, that could be injured, a different ligament. Sometimes people with medial hamstring pain can feel pain on the inside aspect of the knee. Stress fractures can cause pain there. There's definitely what we call in the field a list of differential diagnoses, other possibilities. But hopefully it's just a MCL strain, a medial collateral ligament strain.
Right.
And you do the friction massage and you continue to take it easy. And if all else fails, a small injection into the ligament is almost always curative. Sometimes in difficult cases of ligamentous injury, we do what's called Prolo-Therapy. You might be familiar with that term. It's a very old-fashioned treatment that helps restore ligaments and other structures. And now more recently, I'm using PRP, it's platelet-rich plasma, and stem cells for the more difficult cases. But that's just a topic of another conversation. You need to, number one, have it diagnosed not over the phone, and try this.
Correct.
If the diagnosis is correct, do this friction massage business.
All right. Is
All
there
right.
any one food that you might know for a ligament strain like this in the knee? Are there any couple foods? Because, you know, you do hear a few things.
I think that is all fallacy.
Really?
I don't think there's any truth to it at all. There used to be, well, you know, let me say this. Nutrition is terribly important for healing of ligaments and everything else. And to heal, you need to have adequate protein. You need to have adequate vitamin C is very important to make collagen. But our diets are loaded with good nutrition. I don't think we have to supplement our diets unless somebody is on a real weirdo fringe diet and, you know, only eats, you know, brown rice and nothing else or something like that. Then maybe you do have to pay attention and get some vitamin C and some protein. But I don't think there is any. I think that that's a fad. I think that that's fallacy and fable and legend. I think that the problem about nutrition is that we all eat too much and we have too much sugar. It's not that we're not getting enough nutrients to heal our ligaments. We are. You have, you know, you need protein and you need proper vitamins, but you have all that. And I think the rest, you know, you go online and you look it up, and you'll find a lot of things that refute what I just said. But anybody can write anything on the internet. I would be careful with that, Daniel.
Sure. Well, thank you so much.
All right. Good luck with this. And thanks for calling. Take care.
Thank you.
Bye-bye. Yeah, you know, people always come to me. It wasn't just Daniel, but a lot of people come to me with a complaint here and there, and they say exactly what he asked. What can I eat to make this better? Is there any foods, you know? And while nutrition is a major problem in the United States, I don't think our diets are lacking for the types of nutrients that we need to heal. After all, we're healing every minute of every day. We're scratching ourselves. Our gut is getting repaired. We're making new proteins. We're constantly fixing ourselves every minute. We have plenty of nutrients to do that. Our diet as a culture, as a society, America or Western culture, is not faulted because we're not eating enough foods that allow us to heal. It's faulted because we're eating too much food generally and way too much processed food with added sugar in it and all kinds of other crap. And I started to talk about this earlier. I might as well segue into it now. You know, I told you I'm starting to help patients lose weight as part of their overall rehabilitation program. So if you have arthritis of the knee or a bad back, it's not enough anymore for me to figure it out and fix it, and people come back and they say, oh, God, thanks so much, Dr. Portner, for fixing my knee or fixing my back. I really appreciate it. I have my life back. That's not good enough anymore. Now I'm taking the next step and trying to prevent the recurrence. And if people are overweight and they have arthritis in their knee, there is no hope. You know, they have to lose weight or they're going to sign up voluntarily for a lifetime of big-time knee problems. Anyway, what I'm trying to get to is this theory. It's not mine. I've been reading about it, and it makes a lot of sense to me. That a lot of people think we're addicted to food, and I guess some people are. They eat when they're nervous. They eat when they're depressed. They eat when they're bored. They eat when they see something they like, you know, and they're driven to eat, and they're driven to eat more than they need to. And they sometimes say, I'm addicted to food. The theory is that actually we're addicted to sugar, that all through evolution, sugar was not that available. Yeah, there was honey, and that was sugary, and there's sugar, of course, in fruits if you could get it. But added sugar is basically a very new phenomenon, and you know Hawaii has a part of that history with our cane. We're eating too much sugar, and it's not something that we're used to. And evolutionary, we crave, you know, if you have sugar, that's calories, eat more of it. So it makes sense. But people are addicted to sugar. And if you go walk past a vending machine, you'll see every single item in that vending machine has added sugar. And it's my theory, not my theory, but it's a theory that I ascribe to, that I agree with, that you can lose weight and eat more healthy if every time you buy something at the grocery store, you read the label, ingredients, and if it says added sugar or high fructose corn syrup or natural fruit juice concentrate, that's all added sugar, and that's what's killing us. That's what's making us obese. You see a big fat kid, big obese kid walking around with a big gulp in their hand, a 64-ounce glass of water with sugar in it. It's like 800 calories of sugar, and that's why they're obese. Anyway, that's a conversation we maybe need to have next week. Now it's over, or the show is over. Not too many calls today, but I hope you all enjoyed it. Go have some fun, eat less, and I'll talk to you again next week. Bye-bye.
Thank you for listening to The Moving Body. I hope you enjoyed the show. Remember, if you're having problems with your arms, legs, neck, or back, and would like to get an appointment over at the office on Pe'ikoi Street, you can give us a call, 596-7300. We're open 6 days a week and have a full line of doctors, therapists, EMG, and a great office staff to assist you. We try to respect your time like we hope you respect ours, so people are seen on time. You don't have to expect to spend the whole morning if you have a 9 o'clock appointment. We'll try to see you right then and there. Remember the warning signals that I talk about throughout the show off and on. If someone tells you that it's only your age to live with it, that the x-ray is normal, nothing's wrong, that it's, quote, arthritis or bursitis or tendonitis, but they haven't really examined you very carefully, be cautious about that. Ask for another opinion. If you're told to have surgery, ask for another opinion. If you're told nothing else can be done about it, you want to say, well, maybe you can refer me to another specialist. Maybe they have a better idea. Don't just accept those kind of things. Don't forget to tune in next week, same time, on KHVH. Go out there and exercise this weekend. It's the single most important thing you can do for your health and body. Health cannot be bought off the shelf. Special nutritional supplements is not